And our next speaker is a globally renowned cardiologist from Delhi, Dr. Ashwani Mehta. And over to the chairperson, Dr. Sajid Andari and Dr. Ashutosh Singh. Dr. Sajid Ansari. He will be speaking on, is ejection fraction the best metric for heart failure, or has time come to look beyond it? Dr. Ashwani Mehta, please. You can share your slides.
Sure. Thank you so much for giving me the opportunity today. It's a wonderful session and I'm enjoying every bit of it. It's really nice to be here among all these stalwarts. Well, I'm going to talk something about ejection fraction and is it still the best metric for heart failure, or we should still start thinking beyond it. So we all know this, there's nothing new. What we know is that we have classified heart failure over the years. Initially, there was nothing known as a mid-range ejection fraction, but now we know that there is something known as a mid-range, and we know anything less than 45 is reduced, 41 to 49 is mid-range, FF is more than 50. And of course, recently, after the advent of ARNI, we saw that there is improvement in the ejection fraction. So attempt was made that we need to reclassify this, and we introduced this heart failure with improved ejection fraction. So, and we started classifying it because now no longer this classification or fitting it into HFpEF or mid-range in a patient of HFrEF, the same thing would true, because these patients would still require beta blockers, would still require ARNI. So the whole question of ejection fraction went out of the box, and a new terminology, heart failure with improved ejection fraction, came into being. There are certain limitations. We all know about it, the individual variations, the leave aside, the various machine and the operator related issues. But then there are also, issues related to intrinsic myocardial contractility. Then we also know that it may not be really translating into any kind of a great prognostic evidence because it's maybe different. And the ejection fraction, which is measured, is usually eyeballing, but then we know that we need to take into account so many other parameters, and still there are certain standardized ways of doing it, but then still we need to look beyond it, and this is what has been published. So what it did that this year in April 2025, this brought about a new joint scientific statement on ejection fraction. And this was by various leading organizations working in heart failure. And for the first time, we had a sort of consensus of HFA, ESC, and the Japanese guidelines, the Heart Society, and they came out that it may not be okay just to simplify this complex category. Why? Because the evidence shows that these static categories may oversimplify the complex and the evolving nature. And there may be difference in the treatment and the way we treat these patients based on ejection fraction, and we need to look beyond that. So when we look beyond that, what we find that there are various other ways to look at ejection fraction, and I'm going to talk about few of them. Now, let's first focus on the CMR. When we talk of CMR, we know it is more precise, reproducible with ejection fraction volumes, and serves as a contemporary comparator as far as the compared to the other imaging modalities is concerned. We can pick up the fibrosis and scar with late gadolinium enhancement and also tissue characterization, which is the T1 imaging, which is specific for the fibrosis. We can also pick up the inflammation edema by the T2, and special studies can pick up the iron and also the extracellular volume. So you get little more information, much more information than what you get on the ultrasound, the echo-based ejection fraction. You can also get pulse fluid dynamic sequences that can assess the intraventricular flow assessments, myocardial energetic structure and fine structure, and also the emerging molecular techniques. But we know it is useful in diagnosing and also phenotyping patients of heart failure. So heart failure patients, you can pick up that this patient, based on a CMR, could be having ARVD or could be having sarcoidosis, and then you can treat them appropriately. So it's become a sort of must in patients who have ejection fraction which is low, but still it is not yet the clinical standard for LV assessment. There are a number of reasons. The high cost, limited availability, even in the city of Delhi, sometimes, there is a lot of difference of opinion what we are seeing on the MRI, and we need to spend a lot of time. And patients also sometimes have claustrophobia and noise. Now, if we compare these two, we'll look the evidence from the Stitch trial of 204 patients, where patients with ejection fraction of less than 35 were enrolled, and they had the core lab measurements done by the LVEF. And in these patients, when we did the CMR, there was found to be a difference of 7.3%. So which would suggest that they would change the way we are treating them. So there was a huge poor correlation. And the results suggest that as many as of 20 to 25% patients in Stitch would not have qualified having ejection fraction less than 35 if the CMR was done. So great differences, but still evolving CMR. But if possible, I think a great tool to learn more about heart failure. What about other techniques? 3D echo, contrast enhancement, endocardial definition, the AI-based, there are various machine models which are available, which do, predict the ejection fraction and tell you more about that. And also we have the speckle tracking. We can measure the GLS, the circumferential and the radial strain. Among them, the GLS now is emerging. And there's a high precision, better reproducibility, increased ability to detect the subtle LV systolic functions than the LVF, especially when patients have preserved ejection fraction. This is a great tool. And that is the reason there is a significant uptake in the usage of speckle tracking. And if you see here, we know that today there are various algorithms which identify heart failure with preserved ejection fraction based on various parameters of strain and the speckle imaging. And measurement of strain on speckle tracking is an independent predictor of all-cause mortality, which is regardless of the ejection fraction in patients of HFrEF. Now, what has happened, the guidelines, both the ACC and also the Heart Failure Association of India, now recommend that we must do the global longitudinal strain for heart failure diagnosis. And I think the time has come that whenever we are looking at heart failure, which is a clinical picture and the clinical diagnosis, we need to move beyond and look at the GLS, because that will give you a very decent idea of the subclinical LV systolic function, also diastolic dysfunction, and also predict the risk of heart failure and the recurrent events and even hospitalizations. So if I broadly see the clinical applications, clearly we know it's more sensitive tool for detecting early contractile improvements. Also, there are a number of studies done with ARNI where people have picked up earlier changes which do predict that these patients would improve in future. It can also detect the subtle myocardial deformations. Supposing your patient is on various chemotherapeutic drugs, you can pick up certain parameters which can predict that these are the patients who are going to become worse with your chemotherapeutic agent. And additionally, you also get an incremental prognostic value on various clinical scenarios of heart failure. So it's a very practical tool for monitoring the early benefits of guideline-directed medical therapy as well. So given these benefits, there is a need to incorporate this in patients of heart failure. And what is the evidence? If you look at the evidence, there is evidence from number of studies which have shown number of meta-analyses which have been done, and also, general population studies. And one of the biggest studies from the Copenhagen City Heart Study 2017 published in JACC. And what it showed was that GLS is useful for prognostication in preserved ejection fraction. Number of studies in HFpEF, and like I talked about the cardio-oncology studies are there, which talk of GLS reduction of more than 15% predicts the AF decline and cardiotoxicity. So you get evidence and then you can modify it. Now, if you add biomarkers to this, you get even better, superior risk stratification, which enhances the accuracy. So where is the role of ejection fraction? Well, we all take all these things together, and today the time has come that we must utilize GLS and biomarkers. When we talk of biomarkers, natriuretic peptide obviously is recommended for the diagnosis, prognosis, and also, to know the outcomes. And the all clinical trials, which are being done with guideline-directed medical therapies today, we are using NT-proBNP to guide patients for the patient selection. And unfortunately, even now, we don't have one single marker which can substitute for ejection fraction. So we need to take all these things in totality. But the other biomarkers can give you evidence of myocardial injury, like the troponins, the hard-type fatty acid protein, and also the oxidative stress in the form of myeloperoxidase. Then we have various inflammatory markers, and also the extracellular matrix remodeling markers like the soluble ST2, which can predict the long-term outcomes in the patients. So if you look at heart failure today, so we have on one hand ejection fraction based. On the other hand, we also need to incorporate evidence from the CMR. We need to do a GLS study. We also need to take into account the biomarkers. So just strict, rigid compartmentalization based on ejection fraction is gone. Another very important thing is that in the evolving scenario of these guideline-based therapies, there is a great change in the trajectories of the patients. A patient with HFrEF today could become improved ejection fraction and fall into the mid-range, or become even HFpEF. Many HFpEF patients would go down, become mid-range, and also become reduced. So what do? Do you treat them differently? Do you need to treat them out of the box and think what is going to be the best? So that is the big challenge. And we know that this is not common. No, this is a paper published this year in 2025. And this shows a time course that many patients would change their category if we have a rigid classification based, and then we can't treat them based on the same drugs. So we need to think about this. And typically 3 trajectories have been described: the persistent heart failure with stable ejection fraction, where we need to optimize the guideline-directed medical therapies; then worsening heart failure, where we need to rule out all the causes, and if it's real worsening, we need to give the 5th pillar, which is probably going to come, vericiguat and the other drugs. But one thing is common: whatever is the trajectory, the SGLT2 inhibitors and the diuretics will always be needed, and they're going to be the great beneficial pillars along with the lifestyle, including the exercise. And this typically shows, this graph shows that if you see the SGLT2 and the loop diuretics, they remain static, whatever is the ejection fraction, reduced, mid-range, or the preserved. But with the ACE inhibitors, ARB and ARNIs, the evidence in the preserved is much less, and so is there with the beta blockers and MRA. So just to conclude, I think time has come to rethink ejection fraction in heart failure alone. LVEF is not just enough. We need to move ahead. We need to look at the trajectories rather than the static values. We need to use the advanced imaging techniques like the MRI, the speckle tracking, and maybe 3D echo, where you can see the borders much better. So is GLS a game changer? Probably we need to wait a little bit more, but as of now, it is guideline recommended therapy, one of the prognostic tool, one of the tool to detect early LV dysfunction and also predicting the cardiovascular mortality. So if we treat heart failure, we need to use GLS, and same is true with biomarkers. The another challenge which remains is with the device therapies. Today, if you look at device therapies, there is a rigid cutoff. If you have less than ejection fraction, 35%, then you give ICDs. What about those patients who require ICDs and their ejection fraction is more than 35? Same is true with the CRM, the cardiac resynchronization devices, and also with the CRM modulation devices. Then Barostim, they're all just fixed at a particular cutoffs of ejection fraction. But what about if your patient is prone for certain cardiac death? So we need to move beyond ejection fraction, look at the symptoms, comorbidities, ejection fraction, look at a patient who has got a severe mitral regurgitation, ejection fraction of 50%. Would you, and a worsening heart failure, would you not go for a mitral clip in this patient? So that provokes a great thought. And the guideline-directed medical therapy, we know, works across the EF spectrum, but not all, especially the SGLT2 and the diuretics if required. But we need to think beyond ejection fraction. I think the time has come now. Thank you so much for your kind attention.
Yes, Dr. Ashutosh Singh.
Thank you so much, Dr. Mehta. So to conclude, while ejection fraction is a very valuable tool, we know, for assessing the heart function and classifying heart failure, it has its limitations, as aptly told. So a comprehensive approach that includes more diagnostic tools, biomarkers, and clinical assessment is necessary for the accurate diagnosis and management of heart failure. The topic is open for discussion, please.
Dr. Mehta, in times to come, will a combo of GLS and biomarker replace ejection fraction, or a combo of all three will continue, ejection fraction, GLS, and biomarkers?
Dr. Manoria, that's a great question. And I think as things stand today, we just can't do away with ejection fraction. So if a patient is at a periphery, he is looking at a patient with heart failure, ejection fraction really gives him a very important way to look at LV dysfunction. And we must bring it down and tell them that heart failure is a clinical diagnosis and the way you treat it can be based on ejection fraction. But you are very right. It is not going to be future. I think it is even present, even now. Today, even if we are treating heart failure, we need to combine all the three. Ejection fraction and the various dynamics on echo, plus the GLS and also the biomarkers. All the three need to be taken into account even now.
The other issue is the cardio-oncologists have been using GLS for a very long time, but its utilization by echocardiographer in coronary artery disease and other disease has made a very slow progress. What has been the reason for it?
Well, I think people have not really looked at it in great detail, and it has escaped attention. But today, I think most of the people who are doing echocardiograms and who are dedicated echocardiographers are doing, all of them are doing GLS. And I think the uptake in the last few years has really gone up. And especially those who treat heart failure, the diagnosis of heart failure with preserved ejection fraction can be made on the basis of GLS based so many parameters. And I think the uptake is increasing and the time has come, I think, already that we have to embrace it in a big way.
The other issue which is commonly discussed by the physician is there a direct correlation between ejection fraction and shortness of breath in patients with heart failure?
Yeah, so this is a very important and interesting question. And I've been asked many times, and I always tell them that if I have to say one particular thing which is related to heart failure, it is shortness of breath, the gold standard. And the gold standard is it is related to elevated left ventricular and diastolic pressure. And your echo, ejection fraction cannot measure that. So that is the reason we need to tell them very clearly that heart failure is a clinical diagnosis. And if you just use ejection fraction, you will be missing so many patients of heart failure. And we need to take it down and tell them that mid-range and preserved ejection fraction, patient can still have heart failure. It's a totally different entity. Ejection fraction is just giving you the amount of volume which your blood can be pumped by the heart. That needs to be made clear to them.
The skeletal muscle